Good evening, esteemed colleagues. We have Professor Kanna sir. Good evening, sir. Dr. Pritish, Dr. Hitesh Andaria, Professor Sahai sir. I could see Professor Shyam Kumar Gupta, the head of the Department of Government Medical College, Jammu, joining. And I could see Dr. Sandeep Bamidi.
Yes, sir.
And
Good
I
evening,
hope
sir.
Dr. Venkat Reddy sir is also here.
Yes, sir. Good evening,
So,
sir.
warm welcome to all the faculty. Good evening, everyone.
Good, sir. Good, sir.
So, we have for the first time a candidate from Jammu. Thank you, Sham sir, for kindly permitting your postgraduate for this session. And I warmly welcome you as well to be part of the faculty panel here. And Dr. Smriti is a postgraduate resident from Government Medical College, Jammu. She's going to share a presentation on right iliac fossa mass. Faculty, kindly take over. Good luck to you, Dr. Smriti. The Smriti, you will be allowed to present the history without any break in between. At the end of the history, you please sum up and then come back to the first slide. The faculty will lead you through questions or comments, and then we'll take it further. The same way will happen through the clinical presentation. And she also has imaging and colonoscopy and other images. So the initial half an hour of discussion will be based on the history part, and later we move on to the clinical part and management and operative surgery. So good luck to you, Dr. Smriti. And once again, on behalf of all the faculty, I congratulate those who have all joined the NEET SS. And a lot of information have been received from many of them that students who are presented here already has got good placements in the NEET SS. I also wish people who are in the wait list also get selected in the second round of counseling. Good luck to all of you. And then a few of them have got also the INISET done well. So we also wish them warmly for getting a good seat in the upcoming session. So with that, we move on to the presentation. Faculty, please take over. Dr. Smriti, please introduce yourself, your unit chief, head of the department, and start your presentation.
Good evening, everyone. Myself, Dr. Smriti. I'm a second year postgraduate from Surgery Department of GMC Jammu, and I'm presenting a case on right iliac fossa mass under the guidance of my guide, Dr. Shyam Kumar Gupta. Should I start, sir?
Yeah, please go.
Yeah, please do.
Yeah.
So we have a case, a 65-year-old male, laborer by occupation, presented in OPD with chief complaint of swelling in right lower abdomen for past 5 months. History of presenting illness. So a 65-year-old male presented with chief complaints of swelling in right lower abdomen for 5 months. This swelling was insidious in onset and has progressed over time to reach its current size. There is also a history of generalized weakness and fatigability present for past 7 to 8 months. History of anorexia and unintentional weight loss is also present for past 6 months. History of 3 episodes of melena for past 2 months. There is no history of associated pain. There is no history of vomiting, loose stools, constipation, or any altered bowel habit. There's no history of chronic cough, hemoptysis, no history of fever, night sweats, Riger chill, and no history of backache. Past history. There is no history of hypertension, diabetes mellitus, thyroid disorders, bronchial asthma, epilepsy, or tuberculosis. No history of previous hospitalization and no history of previous surgery in past. Personal history. Patient is non-vegetarian by diet and a chronic smoker. He is a chronic BD consumer who consumes 4 to 5 packs daily for past 35 years. He is non-alcoholic, has normal sleep but disturbed appetite, normal bladder and bowel movement. Family history. There is no relevant family history.
Yeah, okay.
Yes.
Dr. Smriti, let's go to your first slide.
Yes, sir.
First of all, for any slide presentation, there's a norm for it. There are certain norms.
Yes, sir.
Certain fonts are acceptable, others are not. like Tahoma or Calibri or Arial, they acceptable, right? The title slide should be of 40 fonts, 40 size 40 font, and the rest below should be of 30, but not less than 28. Okay, so your fonts on the next slide are very small, right? Also, this red light in line in between is disturbing. So you should learn to make your PowerPoint, which is acceptable. Go to the Google and check what are the norms for making a PowerPoint. Okay. Okay. 65-year male with
I think
swelling in
Smriti,
the
one of the very
right.
important thing in your slide is all letters are capital here. That is
Right.
not acceptable, isn't it? It has to be the running letter. You cannot read the capital letters.
They're
So if there is some
disturbing, and
heading
they
is there,
feel
you
that
can
you're
put as a capital letter, but otherwise it should be running letters.
Yes, sir. I'll take
Okay.
care of it next time.
Yeah.
Yes.
This is just a learning a lesson to be learned. Okay. So 65-year male with a lump in right iliac or right lower abdomen for 5 months. What do you think about it straight away? What comes to your mind?
Uh, so, taking into consideration the age and the
Mhm.
duration of this lump, it seems to be a
Mhm.
chronic pathology.
Chronic pathology. 6 months
Ye-
would be 5 months of chronic pathology.
uh, yes, sir. A 65-year-old male, laborer by occupation.
Okay. What chronic pathology are you thinking of in an elderly in a
So
65-year male?
Considering the Indian setup, the most common thing I can think about is either it can be a this TB, or it can be a CA related to the right colon.
Okay, so you think tuberculosis at the age of 65 is commoner than malignancy
So the
and
malignancy
5 months
is
history.
malignancy has got above 50 in fifth to sixth decade of life.
In fact, the
Life
norm is that if anyone over 60 with a right iliac fossa lump or a right lower abdomen, think of malignancy other unless
malignancy is
tuberculosis.
more than yes, sir.
Okay, next slide. Okay, now again, like we said, it's very small. Progressed over time to reach its current size. What is its current size approximately?
So 5 to 4 centimeter. I have mentioned it in my this.
No, that's fine, that's fine, that's fine.
5
But
centimeter.
in history also you can say you can ask the patient and you can gesture that this is so much and you can interpret it in centimeters. Okay, let's go back.
Yes, sir.
We're not talking of your examination at all.
Yes, sir.
Okay, history of melena, and then there's no history of melena, which is wrong, I think.
Yes,
You
sir.
must have
It's
done it
good.
by mistake. Yeah, so we associated pain where?
So no history of associated pain.
Where?
No history of associated pain with the swelling. So the RIF.
Abdominal. You say abdomen.
Yes,
Abdominal
sir.
pain,
Yes, sir.
right? Loose constipation. Okay.
Yes, sir.
Backache. Next slide. Don't make it past history, make it medical history.
Yes, sir.
Because don't make it a past history, it is medical history. Hypertension, diabetes mellitus will continue as such even now if he has one.
Yes, sir.
Okay.
Yes, sir.
Chronic smoker. Next slide, please. What family history are you looking for?
Sir, family history. If there is a history of this uh, death due to malignancy, I'm basically.
How do you take that history?
So
Suppose the
I
patient died of say a sarcoma.
Yes, sir.
Would it be relevant to your case?
So one of the differential can be this peritoneal tumor. So of course, sarcoma can also be.
Okay. So tell me what history it's multitude, but there are certain things which is very common
Yes,
running in
sir.
the family.
Yes, sir.
There are certain malignancies which are very common which run in the family in this case?
Sir, asking about colorectal carcinomas in the family?
Of course, I mean that would come to your mind first, wouldn't it?
Yes, sir. Yes, sir.
Then there are certain syndromes,
Yes, sir. Yes, sir.
right? So
Yes, sir.
that's what I'm saying. Just if someone asks you, you have to tell me what are the colorectal cancers which run in the family, what are the other syndromic conditions which run in the family which can lead to this.
Yes, sir. FAP syndrome, we have HMPCC syndrome.
So are they seen in 65-year-old?
So the sporadic cases of this tumor are more. If I take into consideration the familial, the sporadic cases of the carcinoma are more.
No, I'm saying those which run in the family. Of course, sporadic is more.
Yes, sir.
Familial is less. But then I'm asking about familial.
Yes, sir.
So what are the syndromes which are like this, which are syndromic?
So we have the Lynch syndrome, one.
Right. Right. Then
So
look, you have benign, you have malignant, you have
yes, sir.
hematomas, you have Peutz-Jeghers.
Yes, yes, sir.
You've
We
got
have
to-
him.
right?
Yes, sir. Yes, sir.
That's what it is.
We
Nati,
have.
you should know all the benign and the malignant tumors of the colon and the small gut, which run in the family or which are sporadic, right?
Yes,
And
sir.
which are syndromic. This is what I okay. Next slide. Sir, anyone please.
Just can you summarize the history, what you have said?
So the history: a 65-year-old male with chief complaints of swelling in right lower abdomen for past 5 months, having a history of generalized weakness and weight loss, and also history of melena, points toward
So weight loss is significant? Do you think
yes,
it
sir.
is?
Yes, sir. The weight loss is significant. The patient has this from 75 kg to 63 kg.
Okay, relatively significant. 6 months, we take it as 10 kilos. Okay, it's about 8 kilos in 6 months. Okay. And then patient has 3 episodes of melena.
Yes, sir,
Okay.
for past 2 months.
Okay. And there is also generalized weakness. Okay.
Yes.
Yeah. So then what is this history of loose stools, constipation, and all that you have taken? What is its relevance in this case?
Sir, I wanted to rule out other possible pathologies. Uh, the inflammatory bowel disease, the TB, and all. Yes, sir.
Okay, fine.
Yes,
Hmm.
sir.
Okay, then fever, night sweats, and chills, and all that.
Sir, for that, I wanted to have a different taking into consideration the one of the differential as TB abdomen.
Okay.
Yes, sir.
So you get night sweats in TB abdomen?
Even so in TB, fever, night sweats, rigor chills.
Okay. So other thing you could have told even lymphomas also, no? Sometimes you can get lymphomas. Okay.
Yes, sir. In acute conditions like this appendicular abscess and all, then also
Okay,
we can
fine.
have.
Okay. Anything else in the history that you would like to ask? Now, the family history which you have taken is not significant here because it's 65 years, no?
Yes, sir.
So usually Oliver syndromic and family history, usually they present somewhere around within 50 years, usually.
Yes,
Okay. So beyond that, it's more of sporadic cases.
yes.
So what is your differential diagnosis based upon your history?
So differential diagnosis,
Only based upon your history.
so only it TB, ileocecal TB, or a neoplastic etiology, possibly involving this right colon, sir. Or it can also be a lymphoma. It can also be a retroperitoneal tumor, a sarcoma, or
So,
How do you explain
so-
melena and retroperitoneal tumor in this case?
yes.
So I can also think of GIST.
No, Sar has asked.
Look,
Don't
look,
skip the.
look,
Sar
you
has
can't
asked.
give everything. अब
So,
just भी आ जाएगा everything. You look, you got to narrow down
yeah.
your differentials to
So
what is relevant.
what do you think the cause for melena here? The one is either the something is there within the lumen or something which is infiltrating the bowel. These
Yeah,
are
yeah.
two things, no?
So what is your organ?
Yeah.
Specifically, which organ you are thinking based upon your history?
So I'm thinking about the ascending colon.
So
So
so in right iliac fossa, you are thinking of an ascending colon.
so
Not the
cecum.
cecum, not the
Cecum.
appendix, not the ileum,
So
Hmm.
cecum. I'm thinking about the cecum.
not the testes,
So in my
not the
examination, I
kidney.
have. So in my
No,
exam.
I'm not talking. We are talking of history. We're not talking of
Only
examination.
history. Only history. Sar is asking. So you are telling classically you're telling history in the right lower abdomen.
Yes, sir.
Which organs you are thinking it might be the cause?
Okay, sir. Okay. So I can also think of a testicular tumor if it is an this undescended testis, or I can possibly think of ectopic kidney. Can also be a differential.
So in ectopic kidney you'll get melena.
No, sir.
So that's what I'm asking. You have to narrow down your history.
Yes,
I
sir.
think the melena, the one of the main important history was taken. So you have to narrow down whether it is from the bowel or it is any other organ. So you
So
can't ascending colon cecum because we don't know anything. Frankly,
yes,
we don't have any this thing. So you can tell it's from the bowel pathology. So
yes.
another thing is you asked the unintentional weight loss. You asked what is its significance and what is called as significant weight loss.
So 10% of body weight in 6 months. If a patient loses 10% of current body weight in 6 months, so that's a significant weight loss.
Unintentional.
Yes,
Unintentional. That
Unintentional.
word is very, very important. That word is very, very, very important. Unintentional.
yes, sir.
What is melena? Define melena.
So melena is the black tarry stools, which are suggestive of upper
No.
GI
Give us the
dystocia.
complete definition. Just not just black tarry stool. There are certain other words which describe it. The complete description. Sticky, smelly,
Foul
right?
smelling black tarry.
Black
Foul
tarry
smelling
stool.
black tarry stool.
Yes, sir.
Right.
Which is its significance? Which bleed? Upper GI bleed or lower GI bleed?
So upper GI bleed.
What is that? Why it is a black?
So because of the uh,
Okay.
oxidation,
Acid hematin. Acid hematin.
acid hematin.
Okay. You come to the this thing. We don't
No,
want
so
to wait.
Dr. Smriti, you said it's upper GI bleed. You've got a lump in the lower GI and you're
Yes,
getting
sir.
melena.
Yes, sir.
तो upper तो कुछ भी नहीं है.
Yes, sir.
तो फिर ये कैसे melena हो गया?
So because the patient gave history of this black tarry stool, that's why.
No.
Hmm.
Of course the
This
patient
is
gave it. What do you
Yes.
think about it? How do you interpret it now?
so. Sari is asking.
He's not lying.
Professor is asking. How will you interpret a black colored tarry stool in a lower abdominal swelling? Which you have told from the history.
Yes, sir.
How do you correlate the two? Can that happen?
So in case of this right-sided colonic growth and cecal growth, patient complains of melena, whereas if it's
Of course he
left-sided,
does.
there is
It could,
hematogenesis.
can. No, it can. They can complain of melena. They can complain of microscopic occult blood,
Occult blood,
right?
yes.
So,
Yes, sir.
Occult blood. Now,
so
there's a difference
basically,
between occult
yeah.
blood and melena. There's a difference between the two.
Yes, sir.
What's the difference?
So in fecal occult blood, bare minimum a bleed of 2 ml
We're not talking the amount. What is the basic difference? You just said now there in melena there is acid hematine being formed
Yes, sir.
because of the peroxidase enzyme
Yes.
there. The bacteria is acting on the hemoglobin,
Yes,
right?
sir. Yes,
So
sir.
if the passage is slow, the patient still can get melena because the bacteria is acting onto that acid hematine, onto the hemoglobin. The peroxidase enzyme is there.
Yes, sir.
You get me?
Yes,
So
sir.
melena can still happen in a lower GI beat if the transit time is slow.
Yes, sir.
You get me?
Transit time. That main important is transit time, acid hematine. Today you go and read what is this importance of transit time and how the acid hematine is formed and what are the factors that cause the formation of acid hematine. So you see the pathophysiology from the basics so that you will answer all these questions. Whether it is an upper GI bleed, whether it is an lower GI bleed, why it is common in the upper GI bleed, then you can answer it. Okay, no issue, no issue.
Yeah.
Good.
Yeah, you can get
If it
both
can,
melena and hematochezia in right colon malignancies, and
yeah.
it also depends on the amount of bleed. If it's a very slow bleed, you can have a melena. If it's a large bleed, you can have hematochezia. So that also is like that. Okay.
Yes,
Okay,
rightly
Dr.
Professor
Smriti,
told.
Yeah.
what have you heard of um, carcinoids?
Yes, sir.
Can this be a carcinoid?
So carcinoid, talking about an appendicular carcinoid, it's not that common. So
We're
that's
not
why the
talking of
first,
commonality. We're not talking about commonality.
yes,
We're
sir.
talking about possibilities.
Yes, sir.
So how will you, by your history, rule out a carcinoid? How do carcinoids present?
So patient will have
Yeah, go on. What does carcinoids secrete?
so they are basically the neuroendocrine tumors.
Yeah, so what do they secrete?
So this catecholamines and all.
Catecholamines. Where do catecholamines come from?
So from the adrenal.
Yeah. So
Where they say
what
about
does
that?
You heard of carcinoid syndrome?
Yes, sir.
Why does that happen?
5-hydroxytryptamine?
Yes, sir.
Yeah,
Yes, sir.
Yeah,
So what does it cause?
Yes, sir.
What are the symptoms of a carcinoid tumor?
So I don't know.
Look, this is Smriti. What I'm trying to tell you is that if you know the diagnosis right from the beginning that this malignancy, you'll not keep your mind open. What I'm trying to tell you is that when you get a case, think of all the possibilities which can occur there, right from the terminal ileum to the appendix, to the cecum, to the large gut, to the testes, to the kidney, to the retroperitoneum. It's a female to the adnexa, to the lymph nodes, everything,
Yes,
right?
sir.
And then go about ticking each of them off. Do you get me? Yeah,
Yes, sir.
please.
Niti, in this patient, you have to combine all those symptoms which are there. It's a 65-year male patient presenting with a lump in the right lower abdomen with melena and loss of weight.
Yes, sir.
So you have to combine all these things together and put your differentiator. You cannot put a testicular tumor here.
Yes, sir.
You cannot explain the melena by that. So you have to think of some pathology there which is in the bowel or it is invading the bowel.
Yes, sir.
Okay. So tell one by one, what are the things which comes in your mind, Jay? Which will have a lump in the abdomen and the patient will have the melena, Jay,
And weight loss.
and weight loss, yeah.
So first will be the carcinoma cecum. Then,
Okay.
of course, the TB,
Yes.
inflammatory bowel disease in conditions like IBS.
So does the
Um,
inflammatory bowel disease present with a lump in the right
no,
lower
sir.
abdomen?
No, sir.
No,
But
so that's what
the-
I'm giving you a very,
Yeah, IBS, you said IBS?
yes.
IBS, how do you get a lump in IBS?
So only the history of this.
No. The history itself is a lump, no? You don't
Yes,
get
sir.
an IBS lump.
Yes, sir.
Okay. Yeah.
Then the mesenchymal tumors like GIST.
Yes. Carcinoids.
Yes, sir.
Okay.
Okay.
Lymphomas.
Yes, sir.
All these can give rise to lump and the melena, जो है ना? So
So,
your
you
based
think most
only on
probably
the
this is a
history, yeah,
okay.
these should be restricted, you know. Now tell what is the difference between the altered bowel habit and alternating bowel habit?
So altered bowel habit is when there is alternation in the usual bowel habit of a person. For example, per se, in a case talking about a patient um uh, if he's daily passing stools and because of some this uh, reason or like constipation. Hello, yeah.
Yeah. Tell that. Yeah, I'm listening. Yeah.
Yes, sir. From the usual bowel habit or pattern, that's what is altered bowel habits.
And
Altered bowel.
alternating? What is alternating?
Alternating is, sir, patient is constipated for after that patient's having this loose stools.
So if you think of the colonic malignancies,
Yes, sir.
which has the altered bowel habit and which has the alternating bowel habit?
Sir, altered bowel habit is seen more in case of right side, this left-sided colonic growth.
Right or left? You
So
have to
left
choose
side,
one.
left side, because
Altered.
because the growth is more annular, and it's
On which side?
critical
Right
time.
side or left side?
So I'm talking about the left side.
So on the left side, do you get the alternating or altered?
So in left side we'll get the altered this altered bowel habit, and in the right side we'll get the altered bowel habit, and in the left side it's going to be alternating.
Yes. So why there is alternating bowel habit on the left side? What is the reason for that?
So because of growth, patient experiences obstruction, and then a time after a certain time, um, um the constant secretions and the this
It is because of the type of the growth which is there. And on the left side, it is the annular variety.
and in the left side it's the annular one, or the
Annular variety
stenosine,
or something.
and
While on the right side, it's the proliferative variety.
proliferative or
Okay. Second is the lumen. On which side the lumen is more, on which side the lumen is less, right or left?
so the left side lumen is compromised.
Lumen is less as compared to the right colon.
Right side.
And because of the type of the growth which is there, there is formation. What is called a stercoral ulcer, you know? What is Dr. Raghu, can you mute
Please,
yourself?
Raghu, please mute it. Raghu, please mute. Raghu, please mute.
Can we go to examination now? I think it's already half.
Yes, sir. I think we will go for an examination.
Yes,
Yes.
okay, I'll just tell you, na? Yeah, just tell that. Stercoral, have you heard of the stercoral ulcer? Circular ulcers are the ulcers which is caused because of the. Dr. Raghu, mute yourself. So, Smriti, you are there?
Yes, sir, I'm there.
Okay, yeah. So, stercoral ulcers are because of the skybella. You know what is skybella?
No, sir.
Skybella is a hard stool.
Okay, sir.
Okay, so because of the hard stool, there is ulceration on the left side because the hard stool. Consistency of the stool on the left side is relatively more solid as compared to the right side.
Yes, also.
The lumen is less, and the type of the growth, which is the stenosing variety.
Yes, sir.
And that is why you have the alternating because of that spurious type of the diarrhea. It is not a true diarrhea, but it's a spurious diarrhea. So patient take the laxative thinking that the patient is constipated, and that is why he's having the alternating bowel habit on the left side.
Yes.
Okay. Yeah. Okay. You can go on. Yes, Smriti, you can go on the examination now.
Journal examination with informed consent. Patient was examined in a well-lit room with proper exposure. Patient is calm, conscious, cooperative, oriented to time, place, and person. Poorly built and nourished, with visible pallor. No signs of icterus, clubbing, cyanosis, lymphadenopathy, no pitting edema. The vitals, pulse rate is 80 beats per minute, regular in rhythm, normal in volume, no radial or radiofemoral delay. Blood pressure 110/72 mmHg taken in left upper arm in sitting position. Respiratory rate is 19 per minute with abdominothoracic pattern of breathing, having a saturation of 96% at room air and temperature of 98.2 degree Fahrenheit. Abdominal examination, patient examined in supine position, exposed from nipple areola complex to mid-thigh. On inspection, the contour of abdomen is scaphoid. Umbilicus is normal in position and inverted in shape. All quadrants move equally with respiration. The hernial orifices are normal. External genitalia is normal. No visible dilated veins or scars on overlying skin. On inspection, there is fullness in the right iliac fossa with well-defined margin. No visible stenosis. No pulse.
Please, Murali, Dr. Murali, please.
Does not move with respiration and the Carnes test is negative. On palpation, liver, spleen, and kidney are not palpable. A solitary mass of 4 cross 5.5 cm is present in right iliac fossa with well-defined margins, firm to hard in consistency, irregular surface and immobile with no skin fixity, upper margin at the level of ASIS, no local rise of temperature, no tenderness. Percussion, liver span 14 cm along mid-clavicular line, no shifting dullness, mass dullness present. On auscultation, vowel sounds present. Digital rectal examination, perianal skin normal, no fissure, no tag, anal mucosa normal, normal anal tone, no ballooning, no prostatomegaly, fecal staining of gloved finger present. So we have a 65-year-old male with chief complaint of swelling right lower abdomen for past 5 months, history of generalized weakness and weight loss, and melena with irregular solitary mass of 4 cross 5.5 centimeter in right iliac fossa with well-defined margins, having firm to hard consistency with uneven surface and negative leg raising test. Provisional diagnosis RIF mass, probably of neoplastic etiology, likely to be CS cecum.
Please come to.
Visible pallor.
Yes, sir.
What do you understand by visible pallor? You said somewhere visible pallor. What is that? The general examination.
Yes, sir.
What is that visible pallor?
So that pallor is present.
So you have to see for that, no? So do you write is a visible pallor?
Visual
No,
pallor.
sir, pallor is present.
There's the pallor is there, okay.
Yes, sir.
And all quadrants are, you told all quadrants are moving equally with respiration. It's not like that. It's all corresponding quadrants. No, none of the all quadrants will move equally with respiration in abdomen. All corresponding quadrants. Okay.
Yes.
And another thing is, come to the inspection and this thing. Palpation, you told lastly localized of temperature and tenderness. You have to comment in the first thing. Once you have examined, there is no scope of examining of tenderness and local rise of temperature. The first point will be no local rise of temperature or tenderness. Examination first you have to see temperature and tenderness. Then you have to examine all other things.
Yes, sir.
Yes, go.
So another thing is, you told an inspection there is well-defined margins. Any photograph is there? Any clinical photograph is there?
No, sir. No,
No.
I don't have clinical photograph. I have a pic of colonoscopy.
No issue. No issue. No issue.
So the palpation slide? Palpation.
Palpation.
అలా ట్యూస్డేకి వస్తాను నేను ఇక్కడికి మండేకి వచ్చినట్టు అవదా మార్నింగ్ కల్లా ఇక్కడికి వచ్చినట్టు అవదా
So you told well-defined margins. You only commented about upper margin. You did not commented about whether it is crossing the umbilicus. What is its extent? And you have not commented any other thing. You only told about only the upper margin.
Sir, because it was limited in the RIF, so I thought the only positive points I should mention in my palpation.
No, is the lower margin palpable?
Lower margin is palpable
Yes,
or
the
not?
lower margin is
Where have you
palpable.
written? Is it
Not
important?
written. Very
Not
important.
written. Is it important?
Yes, sir.
Why?
So because it helps us to distinguish the malignancy pertaining to abdomen in order to differentiate it from the one which is coming from pelvis. In case of pelvic mass arising from
Okay.
pelvis, we won't be able to appreciate the lower border.
Yeah. Okay. So it's
So
you
what
should write that. No?
What is
Median
its
margin
extent?
also.
Medial margin, you have to definitely tell whether it is crossing, it is reaching the umbilicus, it's crossing or not crossing. Medial margin is definitely you have to tell. Because you have
20th
commented
Crossing
before
the
only,
midline.
all margins are well defined.
Yes, sir.
Is the medial margin crossing the midline?
No, sir.
So you
Why is
mention
it
it.
important? Yeah.
You
Next
should
slide.
tell the extent of the all the borders, upper border from some bony point nearby, and medial margin to the umbilicus, and inferior margin to the anterior superior iliac spine, like that.
And you have palpated the thing, and then you're talking about tenderness and local rise of temperature. Shouldn't that come much
I
first?
should have mentioned it before, sir.
Yeah. Next slide.
No, one more thing, in the palpation, is there any importance for the skin fixity for an abdominal lump?
No, sir.
Why
The
are you mentioning that
has-
then? You should tell the plane of the swelling.
Yeah, I mean, is it a intraperitoneal, retroperitoneal? What kind of lump is this?
Sir, it's
Yeah.
intraperitoneal lump.
How did you decide?
You said
So,
negative leg raising test. What does it mean?
negative leg
Negative
raising
means
test.
what does negative mean?
So negative means that on raising the leg, the swelling becomes less prominent.
That's
In
negative.
case
So
of
if the retroperitoneal lump also will become less prominent.
no, sir, we have a different.
The retroperitoneal lump will not become less prominent.
So yeah, leg raising will just say whether it's intra-abdominal or
Only to
parietal.
differentiate from parietal and intra-abdominal. sir.
Yeah, then.
Yeah. So
But
what
you
about
can't different-
retroperitoneal lump?
Yeah.
So we have a test for to differentiate this intra-abdominal from retroperitoneal as well. the knee elbow test.
Anything else? You don't do a knee elbow. You can't push the
So
patient
we
to
can
become a
place
Goa.
the patient in lateral position, and
And then what do you see?
and then we will look for the movement of the swelling with respiration. In case of retroperitoneal,
With
it won't.
respiration. With respiration. Look for the lump. No? If the lump is falling forwards or not, is
Yes,
falling
sir.
laterally or not. Not with respiration. Okay. What about
Dr.
as okay? Next slide. Should we go to the next slide? Let's go to your percussion. Mass dullness present. What do you mean by that? Mass dullness present.
Sir, on percussing that swelling, it was not resonant.
That's a solid mass.
Yes, sir.
What does that mean
Okay.
actually when you have resonance, when you have a dullness?
So, in case of a hollow viscous, we get a resonance.
Dr. Smriti, is that resonant or is it tympanic?
Yes, sir.
Will you use the word resonant or will you say tympanic?
So,
See, all lumps will be dull to percuss only. Okay. Only thing is if you have something which is retroperitoneal and there is a bowel anterior to that.
then we'll get a resonant note.
Tympanic.
Yes.
Tympanic.
Yeah,
Tympanic.
that's a tympanic. Okay. Fine. Okay.
Okay. Next slide. What do you mean by ballooning? No ballooning. What does that tell you? What is ballooning of rectum?
Sir, ballooning in case of chronically constipated patient, we are not
Okay. How did you decide there is no ballooning? When you do a DRE, what happens?
So we simply bend after introducing the finger. We bend it and we try to feel for the wall.
So what is ballooning then? What does it tell you? What's the clinical significance of this?
Sir, it's
Look, this is what I did. If you don't have an idea, never put it. I mean, had you not put it, we wouldn't have asked you. In an
Sir,
exam, try to look. Ballooning has got nothing to do with ballooning is a sign of Ogilvie syndrome. Ballooning of rectum.
Yes.
Right. When you go into the anal canal, the rectum suddenly feels very capacious.
It's more of ileus, no? It's an acute.
It's more of an ileus.
Yeah.
Right. This is to distinguish between mechanical and non-mechanical obstruction. Similarly, in your you've done no radiofemoral delay, all that kind. क्या जरूरत है do you do radiofemoral delay in an abdominal case?
So routinely we don't do that.
Huh? You don't. So you should write what. Okay, tell me the cause of radiofemoral delay now. What are the causes of radiofemoral delay?
So coarctation of aorta.
So you're suspecting coarctation of aorta in this patient.
So I should not have mentioned that.
This is what it is. Mention things that आपने यदि radiofemoral delay लिखा है तो आपने ये carotid pulsation क्यों नहीं लिखा? आपने upper और lower limb का blood pressure क्यों नहीं mention किया? So this is what I'm trying to say, na? In the exam, just write relevant things. If I ask you something irrelevant thing, then you can give me an irrelevant answer. Do you get me? You should always write what you do in the awards, in your OPD. Do you get me?
Next slide. Can you go to the next slide?
Dr. Smriti, regarding your digital rectal examination.
Yes, sir.
You mentioned fecal staining of gloved finger, but your patient has been having history of blackish stools.
Yes, sir.
So
It was
respectively, you
at
may
the,
have to revise that point in history, whether the blackest tool, is he passing those
Yes.
tools every day or is it episodic once in a few days?
yes,
So
sir. I
that
have
history has to be a little
mentioned
more
in
detailed.
No, you have to write the
And
whether the fecal was brown or black. What was the color of
because once
the
you mention fecal, we almost always assume brownish stools.
yes, sir.
And that is the main reason for digital rectal examination, to identify the stool color. The other thing being if there are any nodules that you can palpate or any synchronous polypoidal region. Of course, it's not relevant
Yes.
in this case. And I had another point. Can you go back to your general physical examination, the first slide? You've concluded that your patient is poorly built and poorly nourished.
Yes, sir.
But I don't see any anthropometric measurements. There should be height, weight, and BMI for you to arrive at these conclusions, at least with respect to build. Nourishment, of course, it has a lot of subjective and objective components, but as a postgrad exam going student, these parameters are a must. And an extension of abdominal examination is mentioning presence or absence of palpable left clavicular, left supraclavicular lymph node. Just
Yes.
mentioning no lymphadenopathy does not suffice. You have to categorically mention, especially in cases of malignancy, whether the Virchow's node is palpable or not. So yeah, these are
Very
my points.
important.
Other
Very
systems
important.
you didn't mention, no? Other systems?
Also, the examination on the back and spine is missing.
That's what other systems you have to mention, no?
Yeah.
Suspecting
Okay.
malignancy, you should tell about the chest, bone, and spine.
Yes, sir. Bone and spine, I should have mentioned that.
Yeah. You can at least mention a BMI when you say that it is malnourished and all that, no?
Yes, sir.
And the Karnofsky score, eh?
Yeah. Okay. You can go ahead now with the diagnosis. What do you think now it is?
So my provisional diagnosis is RIF mass, probably of neoplastic etiology, likely to be CS ecum.
So you ruled out tuberculosis now?
Yes, sir. As per palpation, since the swelling is localized in RIF, whereas in case of this tuberculosis, it may be extended to lumbar region because of the ileal pull-up. And also regarding the consistency, in case,
Smriti, let me interject.
Yeah,
yes,
Look,
always.
you just can't come to just a single diagnosis by this. You can't.
You did not have the cecal pull-up in all cases, no?
Yeah.
yes, sir.
So you have to say that, okay, you think this is it, but there are other differentials which you would like to enumerate, and then enumerate the differentials. Do you get me? You just can't put one diagnosis, probably CS cecum, and move on. If you think it's CS cecum, then going for surgery straight away. Why do you have to investigate? Do you get me?
Yes, sir.
Yeah. Okay, how do you manage this patient now? He's in your OPD.
Yes, sir. After my the history taking an examination, I will subject this patient to extended examination. I'll get a ultrasound done.
కాదు రేపు నేను మధ్యాహ్నం 3 గంటలకు వచ్చేయాలి.
It will give me an idea regarding the potential site of this lesion coming from. Also the lymph node status. Also regarding if there is any potential mets in liver, and if there is ascites present or not. After that, since the pathology is
No. You tell how you will approach for this case. We are not telling why you will see, what you will see.
yes,
How
yes.
you will approach for this case. 1, 2, 3.
అవదంటే నాకు కావాలి తెచ్చి నా ఏడ్ చేస్తాను నాకు కావాలి తెచ్చి ఊరుములో
So as per history and as per examination, one thing I know is the disease is related to bowel.
Okay. Now what you will do? Which investigations you will do to confirm the diagnosis? You tell like that. What are the investigations to confirm the diagnosis, to know for the diagnosis and know for the management?
So the easy first go-to modality for diagnosis that we have is for ultrasound, but still it won't clear the diagnosis. It
Hmm.
will just extend my examination findings.
Hmm.
But the gold standard still being the colonoscopy, rather a pan colonoscopy. I'll subject this patient to pan colonoscopy, where I can find the potential lesions. I can
What is pan colonoscopy?
What is difference between colonoscopy and pan colonoscopy?
so in pan colonoscopy we visualize up to the cecum.
Colonoscopy also same, na?
Same.
What is the difference? Don't mention such type of words. Okay. Colonoscopy means you will see up to the distal ileal end.
Yes, sir.
Yes.
Sigmoidoscopy is different. Colonoscopy is different.
Yes, sir.
So you will do a colonoscopy and biopsy. TK.
Yes,
Next,
sir.
next, what you will
Colonoscopy
do?
and colonoscopy are the same things. Okay? They're the same
Yes.
things.
Dr. Smriti,
Yes, sir.
you can approve.
Your investigations in some ways, set of investigations will help you confirm your diagnosis, and the others will help in your management. Now, your patient has pallor, he has an actively bleeding tumor. So the
Yes.
colonoscopy, but the endoscopist may not agree to put in a scope until the anemia is corrected. So in this patient, I think I would want to get a CBC first.
Yes, sir.
So Smriti, don't
So you
confuse.
need to correct the anemia
Any-
first before you are
any-
doing an invasive
I think there
colonoscopy.
are too many people talking
Maybe having an
over.
underlying coagulation disorder.
Could everyone
Pritish,
just mute themselves?
Pritish, Dr. Pritish, please mute. Prakar Vishwakarma.
And Banmiji. Yeah, please. Go on.
कुछ करना तो है नहीं अब चलता भाई
You have been asked how will you manage this case. So I think you have to order your simultaneous your blood investigations and also
Yes,
the
sir.
ultrasound.
So I will get the routine blood
Yeah, if they
investigation.
ask you how do you go into diagnostic investigation one, then you can say colonoscopy.
गुड इवनिंग बॉस
Yeah.
बढ़िया बॉस
Otherwise, when you see a patient, you have to order for all your hemoglobin and all that, no?
Yes, sir.
Yeah. And then your ultrasound and colonoscopy.
Would you like to go for CT scan abdomen?
Yes, sir. CCT abdomen pelvis along with CT
No, you
thorax.
wanted colonoscopy, no? Can you just go and see what is colonoscopy? Ultrasound you wanted, colonoscopy you wanted, no?
Yes, sir.
So in what order you will go? You will go for CT first or you will go for colonoscopy first, and why?
This colonoscope, through colonoscopy, I will have a better visualization of the luminal pathology. Also it will ascertain my diagnosis because I will get I can also take biopsy. And also through this colonoscopy, I can see the possible synchronous and the metachronous.
So you will get a pathological diagnosis and a tissue diagnosis. That's true. But
Yes, sir.
and what is the role of CT scan then?
Sir, for meds, for to look
Only for meds.
Or for any pathology which is not in the lumen. You
Yes,
get me?
sir.
Yeah. For any pathology which is not in the lumen. You get me?
Yes,
So for
sir.
that you get a CT done.
CT
Any
done.
other DD for your case like that. So you can rule out all those things, CT.
That is one. And second thing is whether since you are suspecting malignancy, you have to go for the staging. You can stage the tumor.
Yes, sir. Through CT, I'll be able to stage. Yes, sir.
So that should be the answer that you are, since you are suspecting malignancy, any malignancy, first you have to have a tissue diagnosis, then you have to have a staging, and according to that, you can manage the patient. So sir previously asked that how will you manage this case? So in that case, you have to answer like that.
Yes, sir.
What will you expect in CECT abdomen in a case of CS ecom? What will you see?
Sir, I can see the growth, involvement of the adjacent viscera. I can look for mets in liver,
Metastasis in liver.
metastasis in liver, ascites, the lymph nodes, peritoneal peritoneal mets, and if adding to it CT thorax, I can look for if there are mets and lungs as well.
Okay.
What are the adjacent organs that you are interested in this case?
Yes, sir.
What are the adjacent organs that you are talking about in this case?
So the organs that will decide my resectability.
Yeah, what is
If
that?
I'm planning this patient for
No,
surgery.
what is that in this case?
Sir, duodenum, the ureter.
It's quite down, unlikely duodenum. Okay.
Sir, ureter.
Yeah, that's important.
Gonadal vessels.
It's mainly ureter, okay? Gonadal vessels also you can sometimes sacrifice, okay? Yeah. Okay. Can you show this thing? Colonoscopy report?
Sir, I have a pic.
Yeah, whatever it is. Okay. So what is the report? Where is the growth? Cecum?
Yes, sir.
Okay. What did they give? It's all.
Yes, sir.
What did they give in the reports? It's an ulcero-proliferative growth in the cecum.
Yes, sir.
Okay. And could they pass the scope beyond and go into the ileum?
Sir, the probe was not negotiable beyond. So they
Okay.
simply took biopsy.
Okay. And what is the biopsy?
So it was moderately differentiated adenocarcinoma.
Okay. Fine. Your ultrasound did not show any metastasis, no? Did you do ultrasound?
So initially,
What was that? What was there in the ultrasound?
so we could not, there was no evidence of mets.
Okay, fine. Then you did CT, no? You said you'll do CT. Okay.
Yes, sir.
Yeah, what is it in the CT?
So there was a growth, but again, it was resectable and there was no evidence of mets per se.
Okay. Okay. It was a growth was there which was not infiltrating into the ureter.
Yes, sir.
Neither the parietal wall. Okay. No other lesions in the any lymph nodes that you could see in the CT? No lymph nodes. Okay. You wanted to look at the duodenum. Did you look at the duodenum? Ureter you could see?
Yes, sir. It was not infiltrating the
Okay.
duodenum or this.
Fine. Chest also you did? CT?
Yes, sir.
CT chest also was done?
Yes, sir. CT chest was also done to rule out the possibility of medicine.
Okay, fine. So your colonoscope also did not have any synchronous lesions?
No, sir.
Okay. So what will you do now?
Sir, I will subject this patient for surgery.
Any other investigation you would like to do?
So I will get a tumor marker done, serum CA levels.
Yes, good. Okay, fine. What is its importance in this case?
So in this case, if the levels are high, it points towards poor prognosis. It does not have a diagnostic purpose per se, but rather a prognostic purpose. But having a
It's
high
only
value,
prognostic. It's only prognostic or something else? Anything else?
so if the levels are raised, then it carries poor prognosis, and
Okay.
it also
What
points
about
toward
recurrence?
locally advanced and metastatic.
Anything else?
What about recurrence?
What about the treatment response model? Can you assess?
Yes, sir.
Huh?
Sorry, sir, I didn't get it.
No. It also is used for the response, no? One is the
Yes, sir.
response to
Yes,
the
sir. After
treatment.
surgery, we yes, sir.
And
After surgery, we
yeah,
get the serial CA levels
yeah.
done
And
to look
also,
for.
and also like sir was telling about the recurrence also, no?
Yes, sir. It
Yeah.
gives an idea regarding the residual tumor, uh, or left or not.
Okay. So what was the CA level in this case done?
So they were normal. They were below 5.
Okay. This is CA 99 they have did. CA?
Yes, sir. We did both the tests.
Okay, fine.
What is the normal CEA level?
Yes, sir.
CEA normal value.
So CA normal value is less than 5.
Units?
Sir, it's
Smokers, non-smokers, anything is there?
the
Anything like that?
compounding factors like its value is seen more in smokers and in other conditions like pancreatitis and obstruction.
Non-smokers, it will be less than 3. Unit. What is the unit? I am asking about unit.
Is it um, in
Nanogram per ml.
nanogram per ml? Sorry.
Go back to the tumor marker slide. Yeah. You can see no nanograms. Okay.
Yes, sir.
So what will you do now?
So I will subject this patient for. I'll plan the patient for surgery.
But you have not seen any hemogram, nothing.
So the baseline investigations, the routine investigations, since the patient is malnourished and poorly built, I will my first plan of action would be to build up the patient since I'm planning for an elective surgery. I'll get tests done. I will optimize the HB. I will optimize the albumin levels so as to. Am I audible, sir?
Yes, continue.
Yes, sir.
What will you plan?
Yes, sir.
What will you plan for surgery?
Sir,
What's your plan?
since we are talking about this, considering it a case of CA cecum, my plan would be to go for right hemicolectomy.
No, what do you mean by right hemicolectomy? What do you mean by right hemicolectomy? For CA, you do right hemicolectomy.
So for CAs, for
What is radical colectomy? What is extended?
Sir, in extended, we remove we remove the right branch of the middle colic as well. We basically go with
How
the
much of the
ligation.
ileum will you take?
Sir,
How much of the ileum will?
Sir, some literature suggests 7 to 10 centimeter, and some say 15 to 20
No.
centimeter.
Literature. Don't quote it.
In
Tell
this
me what
case,
is.
since I'm dealing with CS secum, so I'll take a margin of at least 15 to 20. The terminal ileum would be 15 to 20 centimeter.
And distal?
Sir, yes, sir.
Distal, how much? What lymph nodes?
Sir, the lymph nodes will be uh, the the intermediate lymph, basically the lymph nodes, the ileocolic, the middle colic, and the right
You have to
branch
go
of the
down.
middle colic.
What are the lymph nodes of the colon?
So we have four group. We have four. The
What are they?
epicolic, the one which are present in the wall. Then we
Okay,
have
go on.
paracolic, which are present in the arterial arcade. Then the intermediate ones, which are present in ileocolic and middle
So where
colic,
will you
and
go
then
down
the
to?
principal.
So where will you go down to?
Sir, till origin of ileocolic and middle colic. This right colic and the right branch of middle colic, sir.
No, sir was asking what is the distal margin?
So the margin we take is, sorry, sir.
What is the distal margin, sir was asking, no? What is the distal margin in this case that you are planning to take?
So the margins we take is 5 centimeter.
No, yeah, that's what like
No, distal
that's what
means-
I was expecting. Like, is it based on the length or something else? The margins are decided in colon. I suppose if you take a 5 centimeter margin, can you take out all the lymph nodes? What you are saying?
No, sir. It depends upon it depends on the vessel. The limb.
No, what is the surgery that you are planning to do in this case?
Sir, right hemicolectomy.
So what does right hemicolectomy
So
include?
we remove the this 10 to 15 centimeter of the terminal ileum.
That's what. Is it the length that is important or it's the vessels that is important?
Sir,
What are
it's
the vessels that you
vessel.
take in the right hemicolectomy?
So it's the vessels.
Huh?
So the vessels.
Yeah, what vessels are you going to remove? I mean,
So
ligate.
Sir, I'm going to I'll ligate the ileocolic,
Yeah.
the right colic,
Okay.
and then the right branch of the middle colic.
So it's not the length, no? So if you ligate the right branch of middle colic, will just 5 centimeters if you just cut, will it be enough? It will become ischemic, no? Your colon. Okay.
Yes, sir.
So when you take the right colon, I mean right branch of middle colic, you have to go and cut till that place. Okay, so
Yes.
it's not 5 centimeters. The margins are based on the vascular supply. Okay.
Yes, sir.
Yeah.
You
Usually
have
it
to take the
corresponds to the
proximal
proximal cord of
1/3
transverse.
of that, no?
Yes, sir.
When you are ligating the right branch of the middle colic, the vascularity will be up to the proximal third of the transverse colon.
Yes.
So you have to remove the hepatic flexure and you
Yes,
have to
sir.
remove that. If you ligate the main middle colic artery, then that becomes the extended one.
Yes,
And then
sir.
you have to remove the 2/3 of the transverse colon.
Yes, sir.
Okay. And rightly said, it is not the measurement in that. It is depending upon the vascular supply of the terminal ileum is 5 centimeter or 15 centimeter. That depends on after you have ligated the ileocolic artery at its junction, that how much is the vascularity there at the ileum. It may be only up to 5 centimeter, it may become ischemic, or it may have gone up to 15 or 20 centimeters. Okay. So usually it is 10 to 15 centimeters on the terminal ileum side and the proximal 1/3 of the transverse colon. Okay.
Yes, sir.
So that's why we don't say the length. We just say it's a proximal 1/3, something like that. Okay. So it can be 5, 10 or 15, anything like that. Okay, fine.
So how did you prepare this patient for surgery?
Sir, first, since the patient was poorly nourished and the patient was planned for elective surgery, so the initial purpose was to build up the patient.
So how did you build up the patient?
So since HB was on a lower side.
How much was this? How much was this?
So it was 6.5.
Okay, does pre-operative blood transfusion have anything to do with outcomes?
So, but the optimum HB required
I'm
for
not saying but why. The straightaway question is, does it affect the outcome or not?
Giving blood will have a positive impact on the outcome or negative?
So, but by giving blood, we are optimizing HB, and HB does have
Again,
a
don't,
impact on-
That's
Smriti,
okay. That's okay.
don't beat around the bush.
Yeah, we
Just
don't
tell us
say that
whether,
you don't give blood. We're just asking this thing. Does
suppose
blood
his
transfusion has negative
hemoglobin
impact?
was 9.
Yes, sir.
Would you give blood or not?
So preoperatively, no, sir.
Why? Obviously, we are asking the question. You should say yes. It will. It brings the the prognosis becomes worse. Why? Because blood transfusion causes immunosuppression. Okay, how do you prepare the patient? The patient is fit, otherwise PSC. Now, what do you do?
So
As a
adequate
surgeon, how
bowel,
do you?
so adequate bowel preparation prior to surgery.
What is adequate bowel preparation?
So, so oral
You
laxative.
must have prepared. You operated on this patient?
Yes, sir.
Have you operated? So how do you
Yes.
prepare you must have prepared this was your patient?
Yes, sir.
So how do you prepare the patient? I'm going to tell us.
So, gut preparation.
कैसे करते हैं?
Sir, laxatives and enemas.
Was it done in this case? Was it done? Are you sure it was done?
Yes, sir. Yes, sir.
और क्या करते हैं? चलो और क्या करते हैं? पेशेंट को कुछ बोले थे बिफोर सर्जरी? खाने पीने में कुछ फर्क पड़ता है?
Yes, sir.
What?
So NPO, liquid diet.
NPO.
So prior to
Clear
surgery.
liquids. Clear
Yes, sir.
liquids. How many days prior to it?
So 2
Did you
days.
prepare this patient or not? You tell me. This is what I try to do. As a resident, you should go back and read before about the preoperative preparation of such patients, and then come back and do it. You must not have read. पढ़ा नहीं था ना pre-op preparation. ऐसे ही कर दिया. So you got to give the patient clear liquids for next 24 hours, right?
Yes, sir.
Some people used to give local antibiotics, but that's not required. In fact, it is not to be done because it alters the bowel
Gut
flora,
flora.
the blood flora, right? So this is how. So you got to keep the thing clear. Keep the bowel clear. Okay. So what was the surgery? What was the surgery? The histopathological report. HP report क्या था?
Post this.
Yeah, post surgery.
Suppose. So it was moderately differentiated adenocarcinoma.
That's it. What does do you expect from a pathologist?
So the staging as well.
Yeah. So what was the stage? Pathologist.
So, but we failed to follow up this patient.
You must be having the HP, na? Even if the patient runs away, report to hoga tumhare paas. Okay. Tell me what infiltration into which layer of the gut is important.
So the serosa.
Serosa, of course, naturally is gone out. In the wall of the gut, what changes the stage? Infiltration into the Muscles. Why?
Muscularis mucosa.
Muscularis propria. Why? Why? Because muscles have a good blood supply and a lymphatic supply. So once it enters the muscles, it is bound to spread elsewhere into the lymph nodes, hematogenous spread. Do you get me?
Yes, sir.
Should we call it? I think we've done 1 hour. Dr. Kanagal, sir, Professor Khanna.
Sir, I'm here.
Yeah. I think we've done.
Dr. Smriti?
Yes,
Yes,
sir.
please go ahead.
Yes, sir.
Do you have any doubts or questions to be clarified, Dr. Smriti?
Sorry, sir.
No. Do you have any doubts or questions to be clarified?
So first of all, I need to read.
Of course, everyone, even you
No,
have to
that
read.
is fine.
That's not the point.
Don't feel bad at all. Please. All of us
You've
have
done
come
well.
through all this
Look, you've done
ladder,
well. You've done well.
right? Don't feel bad at all. This is only a stock taking. Please take note of the things where you find difficult to answer the question. Go back and refresh yourself. That is all. There are always parts to points to learn, way to learn. All of us are learning with you along. That's what I would say. So don't feel bad at all. This is only to take stock of situation. Kanna sir, any comments sir from your side?
Whenever you get any case of malignancy and you
Yes,
are
sir.
asked that what are the investigations to be done,
Yes, sir.
there are 3 sets of investigations which are carried out in every case of the malignancy.
Yes, sir.
First set is the investigations to reach to the diagnosis. Second set of investigations are for the staging purpose.
Yes, sir.
And third set of the investigations are investigation for carrying out the treatment.
Yes, sir.
Okay, so like in your patient has a suspected case of carcinoma cecum, colonoscopy is the most important investigation here. Apart from the CT scan and the tumor marker which is there, then you have to carry out the investigations for the staging of the disease, and that is why you do the CT scan and you look for the lungs.
Yes,
Okay,
sir.
do the CT of that. And third are the investigations which are for the fitness of the patient.
Yes, sir.
Okay, so these are the 3 set of investigation has to be carried out in every case. Okay.
Yes, sir.
Yeah. Yeah, Dr. Kanagal?
Yes, sir. If any other faculty would like to add any comment, Shyam sir, would you like to add anything to this?
Yes, sir. Thank you very much. He is my second year postgraduate.
Yes, sir.
This was very nice. Dr. Rajiv and Dr. Khanna, as usual, they have given nice comments to her. Now this is a boost for her to read. And next time when she is going to present, I think that it will be much better presentation.
Of course, we're
100%.
always improving. We're always improving.
Yeah. Thank you very much, sir. Thank you.
Thank you. And with the
Well done,
permission of the
Smriti.
faculty,
Good night.
well done, Smriti. Take care. Good luck to you. So we look forward for it another Friday. Mostly the next week will be vascular cases. We'll share the details soon. Good luck to you. And with the permission of faculty, we call the session closed. Thank you very much.
Thank you. Good night. Good night.